target axillary dissection to minimize axillary surgery post neoadjuvant systemic therapy. Professor Ahmed Adel.
Dissection to minimize axillary surgery post neoadjuvant systemic therapy in breast cancer prospective study. I am Ahmed Abdul Salim, Assistant Lecturer of Surgical Oncology, NCI, Cairo University. This is my PhD research study under supervision of my dear Professor Dr. Hamdi Maragbi, Head of Breast Surgery Unit, NCI, Cairo University, and Dr. Ahmed Farahat, Dr. Tariq Hashim, and Dr. Amira Hamid. Breast cancer patients presenting with nodal metastasis often receive neoadjuvant systemic therapy which can eradicate or minimize the breast cancer burden and nodal disease. Also, neoadjuvant systemic therapy can achieve pathological complete response, which improves disease-free survival and overall survival. Axillary lymph node dissection has been the standard surgical approach in node-positive patients. However, there is associated significant morbidity such as numbness, pain, restriction of shoulder range of motion, and upper limb lymphedema. That leads to the low quality of life or unclear benefit, even within the patients who have pathological complete response after neoadjuvant systemic therapy. This led to the development of sentinel lymph node biopsy, which is a minimally invasive, reliable technique with high accuracy in determining the status of the axilla and led to less morbidity compared with axillary lymph node dissection. In patients treated with neoadjuvant systemic therapy, resolution of all nodal metastasis to be pathologically confirmed node-negative disease after neoadjuvant chemotherapy occurs in approximately 40 to 50%, with rates as high as 60 to 75% in HER2-positive disease. So sentinel lymph node biopsy after neoadjuvant systemic therapy can provide a less invasive method for staging the residual axillary disease after chemotherapy. There are three conditions for the axillary status in relation to neoadjuvant systemic therapy: node-negative breast cancer before and after neoadjuvant systemic therapy, node positive that doesn't respond to neoadjuvant systemic therapy and remains positive, node positive before neoadjuvant systemic therapy that converted to node negative after neoadjuvant systemic therapy, and this is the third group, the group that we are concerned about. The dilemma here is that if you did axillary lymph node dissection, this may be unneeded surgery and you may get your pathology report having your lymph nodes removed zero over what removed. And if you did sentinel lymph node biopsy, there is a high false negative rate, inadequate staged axilla, and there is still nodal metastasis that will affect disease-free survival and overall survival. This is the definition of the false negative rate and identification rate. We here mean by the false negative rate is that how our surgical technique couldn't identify the state of the axilla, how often the sentinel and the TED technique retrieved nodes are negative while there is still positive lymph nodes left in the axilla after sentinel and TED. This is the false negative rate. This meta-analysis done in 2019 showed that the false negative rate in node positive confirmed to node negative patients after neoadjuvant systemic therapy, the pooled false negative rate was 13%, and for any technique, you have your false negative rate to be less than 10%. So what is the effect of the chemotherapy on the axilla that leads to high false negative rate in sentinel compared to upfront sentinel? Why when you do upfront sentinel, the false negative rate is low, while if you do sentinel post chemotherapy, the high false negative rate is high. Chemotherapy leads to fibrosis and shrinkage and induces emboli and debris depositions in the lymphatic roots that can alter the lymphatic mapping and decrease the identification rate. In addition, it leads to unequal disappearance of tumor burden in lymph nodes, so that sentinel lymph nodes are sterilized while non-sentinel remain involved. This is too high false negative rate. What is the problem that led to the elaboration of TED? The problem is that there is high probability, up to 50%, of axillary lymph nodes positive before neoadjuvant systemic therapy to become negative after neoadjuvant systemic therapy with hazardous non-beneficial axillary lymph node dissection. And sentinel lymph node in such cases has high false negative rate more than 10%. This is the problem that led to the elaboration of TED. It is obvious that a high need for a new technique to resolve this issue and decrease the false negative rate and adequately stage the axilla post neoadjuvant systemic therapy. This is the targeted axillary dissection, which is a new technique aiming at decreasing the false negative rate in node positive confirmed to node negative patients post neoadjuvant systemic therapy. What are the techniques for marking the diseased nodes before neoadjuvant systemic therapy? Either a clip is placed, some centers use the radioactive iodine 125, or charcoal black carbon, and under trials the magnetic seeds. All these ways are ways for localization of the diseased nodes before neoadjuvant chemotherapy. What is the number of nodes to be marked before neoadjuvant systemic therapy? In our study, we clipped only one node, and we chose the cases with one node only. But most studies suggest that to offer TED in 1 or 2 nodes, and if more than or equal to 3, don't do TED. There is experience in MD Anderson Cancer Center to clip up to 4 axillary lymph nodes. The technique of TED in our study: selection of the patients from T1 to T3 in one with one pathological lymph node. MDT decision is neoadjuvant systemic therapy. Fine needle of the nodes should be done preoperative to confirm that the disease node pathologically, not radiologically, before neoadjuvant systemic therapy. Then patients will receive neoadjuvant systemic therapy. We here see neoadjuvant systemic therapy as the patient may take neoadjuvant chemotherapy or neoadjuvant hormonal, so it is neoadjuvant systemic therapy. Then after completion of neoadjuvant systemic therapy, we do ultrasound again of the axilla, and there is in our NCI, there is another research work that assessing the sensitivity of the ultrasound in these patients in another research group. We do ultrasound of the axilla after completion of chemotherapy. If there is still suspicious axillary lymph nodes, we do fine needle again. If it's still positive, we do axillary lymph node dissection. If radiological clinical nodal response, post-neoadjuvant systemic therapy is achieved, intraoperative localization, of the previously clipped node is done by ultrasound. And sentinel with dual technique, patent blue and technetium 99 is performed, and the excision of the clipped node. In our study, we do backup axillary dissection to detect the reliability of the study. We do specimen radiograph for all our cases for the resected nodes to confirm the clipped node excision. So we send the pathology specimen of the axilla as the sentinel lymph node biopsy alone, and the clipped node as a separate entity if it is outside the sentinel, and completion axillary dissection. We had a challenge here that the usually used clip in the breast is the Ecicon titanium clip, which costs about 360 or about $120 US. But in our study, we used the inner surgical clip, which is used in cholecystectomy, and it costs about 15 Egyptian pounds, half US, with very good results. The ways of intraoperative localization of the clipped nodes, intraoperative ultrasound, this is what we used in our study. You can also use radioactive iodine 125, and wire localization of the clipped nodes. In our study, we used the intraoperative ultrasound. Regarding the technique of sentinel, we use both dual technique with technetium 99 and the patent blue dye. We used both techniques for identification of the sentinel lymph node. The number of lymph nodes to be removed in sentinel, to decrease the false negative rate, at least 2 sentinel lymph nodes should be removed. And there is a meta-analysis suggested that any suspicious palpable lymph nodes should be removed with the sentinel lymph nodes. This is pre-operative assessment, a day before surgery, pre-operative assessment of the clipped node that was clipped 6 months before by ultrasound. This node was clipped 6 months, then the patient received here neoadjuvant chemotherapy, and now this is the day before surgery. We can see here clearly the clip. This is the Sentinella axillary mapping in our NCI breast hospital in Tajamma, and this is the gamma camera. We have here on the right the Europrobe, and on the left we can use also the gamma camera in our NCI. Here in surgery was my dear Professor Dr. Hamdi Marakbi, and this is the gamma probe of the Sentinella. Here we have a new device, we bought it 6 months before, which is a new probe and new wireless probe. Here we use the gamma camera. The gamma camera has X, Y, and X axis and Y axis. We put it on the suspicious nodes, and see this is how it appears as a sentinel node. This is another case that appears in the gamma camera taking the technetium 99 node. This is intraoperative. This is another case. In our study, we detected the site of the sentinel and the site of the clipped node in the new classification of the axilla, which is CLAW classification 2015. Here is a new classification of the axilla, not level 1, 2, and 3. We here, the axilla is classified as zone A, B, C, and D, according to the lateral thoracic vein and the second intercostal brachial nerve coming from the second intercostal space. So we say where we found the sentinel node and where we found the clipped node according to this new classification, CLAW classification 2015. This is intraoperative ultrasound detection of the clip. This is intraoperative. Here we are looking, we can see the clip inside the lymph node intraoperative. Another case, we can see the clip inside the lymph node. This is specimen radiograph. When you remove the sentinel and the backup axillary dissection, we do specimen radiograph for all our cases, and in all cases, the clip could be seen in the specimen radiograph. Another case with the specimen radiograph, here we can see that the sentinel node is the clipped node, and the other one on the left is the completion axillary lymph node dissection. Here is another case where the clipped node is not in the sentinel. The sentinel is high here, while this is the clipped node outside the sentinel, and this is the backup axillary dissection. You can see the clip. This is the results of the MD Anderson trial 2016, when they used the sentinel alone for detection of the state of the axilla. There was a false negative rate of 10.6%. So in 10.6% of your cases, you will remove the sentinel. They will show you that the sentinel is negative, whereas there is still positive lymph nodes inside the axilla. When they depended alone on the clipped node without sentinel, the clipped node has false negative rate of 4.2%, while the TAD technique, while removing the sentinel lymph node and the clipped node, the false negative rate in the MD Anderson trial was 1.4%. Here is another trial called ACO, American College of Surgeons Oncology Group 2016. The clipped node was in all the sentinel node in 107 cases, and the clipped node was outside the sentinel node in 34 cases. So here we can answer two questions. Either the sentinel lymph node alone, post-neoadjuvant systemic therapy, is enough for staging the axilla. The answer is no. Due to high false negative rate, more than 10% of your patients, the sentinel will not reflect the state of the axilla. The second question, does the addition of TAD to sentinel is enough for staging the axilla? The answer is most probably yes, but further studies is needed with large number of patients worldwide to be incorporated in the guidelines as level 1 evidence. Here we can see that the NCN refers to the target axillary dissection as a recommendation category 2A evidence. We have to take care that the TAD is a very rewarding technique that is recommended as category 2A in the last edition of NCN to be used in patients with primary 1 to 2 diseased axillary lymph nodes confirmed by fine needles that will undergo upfront surgery without neoadjuvant systemic therapy. The scope of TAD is getting wider, that you can use TAD in upfront surgery without neoadjuvant systemic therapy. Here is the referral to clipping the diseased node and do upfront surgery, so that TAD can be used only without chemotherapy. This is a trial, ELINA trial done in Spain. It is similar to our trial, where they used intraoperative ultrasound for localization of the clipped nodes, and the number of patients in this trial was 45, while in our study the number of patients was 68. Part of our preliminary results, in our study we clipped the nodes in 79 patients. Only 76 patients completed their neoadjuvant systemic therapy and planned for surgery. 72 patients showed clinical complete nodal response by the preoperative ultrasound assessment. 4 patients showed failed sentinel or failed to localize the clip intraoperative, so 68 patients are included in our study. This is a flow chart of our patients. In our 68 patients, there was pathological complete response for the breast alone in 29 cases, which is measured by Miller grade for the breast. We used the Miller grading for assessment of pathological complete response. The pathological complete response of the axilla alone was in 32 cases. We used the Satalow for assessment of the axilla alone. Both breast and axilla pathological complete response was in 23 cases, which was measured by residual cancer burden of MD Anderson Cancer Center. In the rest of our study, the false negative rate of the sentinel alone was 16.6%. If I use the sentinel alone for measuring the false negative rate, I have a false negative rate more than 10%, 16.6%. The sentinel didn't reflect the state of the axilla post-neoadjuvant chemotherapy. And the false negative rate of the clipped node alone was 11.1% if I used the clipped node alone without doing sentinel. And the false negative rate of both the clipped node and the sentinel target axillary was 5.5%, actually in 2 cases alone. Another ongoing clinical trials worldwide, there is a Magaline trial in MD Anderson, USA, which uses the MAG seeds for marking the clipped node. This is the RESUS trial in Netherlands, which uses iodine 125. This is the CENTA trial in Germany using the TAD, and the Gania trial in France using sentinel versus TAD. Thank you.
Any question?
Yes?
Okay.
When I used the sentinel alone in my case, in my patients, there was false negative rate 16.6. When I used the clipped alone, the false negative rate was 11.1. When I use both TAD, which is both discordance, why there is discordance? The difference, the clipped node was outside the sentinel in 16 patients.
16
Out of 68.
68, so that presents
How
how many of the cohort?
many of?
Percentage.
16,
Like, how
16
many out, usually,
in 23.5%.
that's too high, isn't it? Like usually, the standard that the sentinel lymph node is that lymph node in an average of about 11 to 12. When it doubles to 23, then there must be a problem either in the radiologist technique or in the interpretation technique. That was the little bit hole that I wanted to clarify. The second point was, now we went
Please speak in the mic too, so I can hear you.
I thought like I'm shouting rather. You know what? Why don't you close that door so we can? Yeah, okay, I'll do that. My question is what? Now you've done a concomitant axillary dissection. Now, throughout the last cohort, the 68 or 70 patients, how many of them you find a disease in the axilla while the sentinel and the clip node came
2
back
patients, false negative rate 5.5%.
Only
2 patients, but the false negative rate here is calculated by, you don't divide the 2 cases over the all 68. You divide them by only the cases that had no pathological complete response as axilla. It has even 1 axillary lymph node positive. So I divided them 2 cases divided by 36 cases, which didn't show pathological complete response. And here is the definition of the false negative rate. I said it.
To make it clarify, you are speaking about a false of putting the clip in the identified lymph node which is positive or not. This is one of the false results.
Yes.
Okay.
I don't want to say it's false, but maybe there was disconcordance between the techniques.
Yes. In our institute in Alexandria University, we usually take the core and put the clip in the same session. The same session.
This is before neoadjuvant systemic therapy. I see the diseased node and I mark it with a clip.
Yes. The point is that, Gamal, are you doing this in the same session, or you take the fine needle, and if it's positive, you'll put a clip?
This is from the radiologist. The patient, they take fine needle or true cut from all cases, and it is very suspicious. And radiologically, they put the clip. And then I return back to the result of the fine needle or the true cut. If it is negative, then I abort this patient, and the patient is managed as a negative case.
This will decrease the false rate, right?
Yes, I get that. But what my question was, why do I have a 23% of my patients has a positive non-sentinel?
Despite we use the dual technique, that's what we found.
Yeah, exactly.
It's a prospective study, and that's what we found.
It's another issue.
But we used the patients with only 1 diseased node. We aborted the patients with more than 1 node.
Maybe it was underpowered. Like if we get more cohort of patients, we will get the power better, and we get.
Maybe the aim of this study is that it is our center, but to implement it in the literature, it needs to be a multi-center study with more larger number of patients. But I think that one day it will be a recommendation category 1 in the NCN guidelines. It is very soon.
Okay.
Thank you.
I want to congratulate you and Dr. Hamd al-Marakibi for well-organized technique and method of the research, right? The point is you didn't use radioisotope material for marking the lymph node before neoadjuvant. You didn't.
There is.
Or you did?
I didn't use. I used the technetium 99 for detecting the sentinel.
Yes, yes.
But leaving iodine 125 for the patient for 7 months, it is unethical.
Okay, this is what I want you, because you said it in the introduction. It's not ethical, and the emission of radioisotope material will not be enough.
This was aborted in some trials because of the unethical issue. But in some trials, they used it in the day of the operation to mark the diseased node on the clip. Yes.
You detect the clipped lymph
Intraoperative.
intraoperative
By
wire.
ultrasound? No, intraoperative ultrasound.
Intraoperative.
And this is like the ELINA trial done in Spain. And it has a high.
It was easy.
It was easy, and the radiologist came to our surgery for a number of cases, about 20 to 30 cases. Then I can do it now alone. I can see the lymph node and see the clip inside it.
I'm happy with you. Cost-reducing method.
It was a
Cost-reducing
from $4,120 to
Cost-reducing method
$250
in
buys the inner
clip
clip.
type. Cost-reducing methods in exchange the wire with the intraoperative ultrasound, and it's very, very good research in our country. Thank you very much.
Thank you. Thank you.